on.
Okay. Yep,
So
I did.
cool. Yay. Okay, so we're starting. Tanner, you know what's going on? We're actually starting on page 5 of the notes.
Okay.
You have the notes from class. You can just put them in front of you and work from those, or if you want to challenge yourself, you don't have, you can try to do without them, depending
Okay.
on how much you've done, but we're just going to start there. So irritable bowel syndrome. Does anybody know anything about that?
Um, no, not specifically.
Okay, so remember this one had the mental component.
So wait, irritable bowel is the same as ulcerative colitis? Is that irritable bowel? Where are we?
So irritable bowel syndrome is a general term, right?
Okay.
Okay, it's irritable bowel was a
Oh, it includes Crohn's and ulcerative
ulcerative
colitis.
colitis, right?
Yeah.
And it had a mental aspect to it, where the other ones didn't.
Yeah.
Okay, so signs and symptoms. IBS is diagnosed when a person has had abnormal pain or discomfort at least 3 times a month for the last 3 months without other diseases or injury that could explain the pain. Okay, the pain or discomfort of IBS may occur with a change in stool frequency or consistency, or be relieved by a bowel movement. Persistent or recurrent symptoms of abdominal pain, okay, altered bowel function without GI damage, and various complaints of flatulence, bloating, nausea, anorexia, constipation or diarrhea, and then IBS accompanies anxiety or depression. So moving right along. So moving on to page 5. So we had ulcerative colitis and we had Crohn's. So if we go here, I got I put that spreadsheet on here, actually on the notes, that explains the differences between the two of them. So what's the difference between what is the big component between these two? What makes these ones special?
They're autoimmune.
They're autoimmune, right?
There's no cure.
What was that?
No cure.
Yeah, there's no cure, and they're autoimmune. So if you're looking at ulcerative colitis and Crohn's disease, so family history, ulcerative colitis, there really isn't a strong correlation with getting that and family history. But Crohn's disease, there's a really strong indication. So if mom or dad have it, there's a good likelihood one of the children or some of the children are going to have it. Okay, and then children can pass it on, obviously, to their children. And so we see that correlation. Locational lesions. So let's talk about this. So ulcerative colitis, the lesions are large intestine, no skip lesions, and it only attacks the mucosal layer. So what do we mean by when we say skip lesions? Or skip lesions, excuse me.
Oh,
that's just when the lesions it could be like an area of lesion skin and then an area of healthy skin and then another lesion. It's just that they skip across the healthy skin. So
it jumps, right? So you're going to see an area of good skin or area of good tissue, an area of diseased tissue, good tissue, diseased tissue. Ulcerative colitis is only in the large intestine is where we see it, where Crohn's disease, it's large and small intestine with skip lesions, and the whole bowel is affected. So we can see it kind of almost anywhere. It can even progress down into the rectum and anus, and so ulcerative colitis doesn't affect as much area of the bowel, where Crohn's affects quite a bit more. Okay, anal and perianal fistulas, they're rare in ulcerative colitis, and in Crohn's disease, they're quite common. So fistulas are like cracks, breaks in the actual skin.
Tunnels?
Yeah, tunnels.
I thought fistulas different than the puncture because they had to lead to another organ instead of just
thank you. Yep, thank you. So yeah, we just see openings from there to something else. So, for example, men and women, right? If a guy has Crohn's disease, okay, his fistulas are going to lead somewhere else than women, but females, your orifices and your structures with regards to your GI and your urinary system are quite closely associated. So you may actually see fistulas between the GI system and then actually the renal system, or the GI system and the reproductive system. A little bit less associated for men because the systems, they're not as close, obviously.
Okay.
Superior system.
Yeah. Okay, so bloody stool. Okay. So any type of bloody stool, it's more common in ulcerative colitis, and it's a little bit less common in Crohn's disease.
Why is that?
Was that? I'm not entirely sure. I know it's, I mean, obviously it's the way that they present and how they damage. So if you look at the layers that they damage, ulcerative colitis only damages the mucosal layer. Well, there's a lot of blood vessels and capillary beds that end there. And so there's just more blood for them to recruit, where it looks like Crohn's disease actually affects the entire bowel. And so it dissects all three layers of those organs. And so maybe it just dissects them, and then that's why there's no bleeding. They actually physically go through, and the blood vessels just go around the damage. Or it just damages the blood vessels and just blocks them as it goes through. So again, we could ask about that, or we can look it up or whatnot. So,
okay. Or we can just accept it before it destroys us.
Or we can accept it before it destroys us. Yes. So treatment between the two of them is exactly the same, except for one thing. So ulcerative colitis, steroid and MAP drugs. So who can tell me what MAP drugs are?
Are those the drugs that are used a lot in chemo and they target specific? I don't know.
They're like designer drugs, right? They're made specifically to that person. So what are some of the scary things with this? What do we have to help people to avoid when they're taking MAP drugs?
I mean, the MAB must avoid bugs.
Yeah, they must avoid any. They're already autoimmune compromised. Like they're already immune compromised, and so they're more likely to get infections and stuff that they wouldn't normally get. So and the MAP drugs accentuate that. Okay, so ulcerative colitis, it may need surgery, it may not. Where Crohn's disease, they'll get surgery to remove damaged pieces of their tissue of their organ, to remove it, to help to relieve the symptoms that people get.
It's true. I know someone that had that.
Yeah, I know somebody's had that pieces removed as well. And they're happier after the surgeries are over. It's not fun to have it done, but when they have it done, they definitely feel better. Okay, let's see here. Okay. I started doing colorectal cancer. So let's get into this. So all the cancers in the United States, colorectal cancer is the second leading cause of death in the second leading cause of cancer death in the U.S. in both men and women. So I think there's actually there's a number one that's different than for both men and women. But when we get to the second leading cause of cancer death, it becomes colorectal for both men and women. But who's more likely to get colorectal cancer, females or males?
Male?
Yep, males are more likely to get it. So they're more likely to develop this kind of cancer. And then by age, who is by age most likely to get this?
Over 50.
Yep, 50 or older. Gender, man, race, black and white, black and Caucasian races have the strongest indicator that they can get it. And then family history, 25% higher instance in those who have a family history of Crohn's or of colorectal. And then medical history of Crohn's disease or ulcerative colitis. So those with Crohn's and ulcerative colitis are more likely to get this, to develop colorectal cancer. And then diet, those who are eating the American diet, high in fats and refined sugars, flour, low in fiber and low in vitamins. Again, you're giving yourself a stronger correlation. You're increasing your risk of getting colorectal cancer. So eat good and take care of yourself. And then obesity, lack of exercise, smoking, alcohol consumption, or other risk factors that elevate your risk of colorectal cancer. Okay, now let's talk a little bit about the pathophysiology of this guy. So if you're on page number 6 of the notes, it has actually a good graphic that shows this. So stage 0 of colorectal cancer, where is that lesion actually at? Where's the cancer developing?
In the colon wall.
Yeah, it's right on the surface of the colon wall, and it hasn't bisected down any lower than that. Stage 1, it's starting to dig down into those tissues, and it's getting into the second layer. Okay, stage 3, it's embedded down into the basement membrane, into the adipose tissue. Stage 3, it's just getting bigger. And then stage 4, it's starting to metastasize and leave. It's pretty much firmly seated in the colon, and now it's leaving and going. In this case, it's showing it's transferring to other organs, and it looks like it's going first to the liver. Let me ask you guys a question. Why would the liver be the first place that any cancer from the intestines would metastasize to the liver? Can anybody tell me that?
Is it the closest?
Okay, remember from our anatomy class, the blood supply from the small and large intestines leaves the intestines and goes to the hepatic portal system into the liver first, and then it goes to the rest of the body. Oh. So it's actually blood supply wise. It's leaving, it's metastasizing into the lymph nodes and into the blood supply. It's breaking off, portions of it are breaking off, and its first major destination is going to be the liver. So via the hepatic portal vein, and then again, obviously it's larger structures, so it's just getting stuck in there as it goes through those hepatocytes during the filtering process in the liver of that blood. They're just getting lodged in there somewhere and sticking, and then they grow.
Makes sense.
Okay, are there any questions about that? Okay, so it says here a key thing with this: colorectal cancer is increasing rapidly in the 40 to 50 age range. So it's actually in my age range, it's getting more common. Okay. National Institute of Health study found most potential diagnosed with colon or rectal cancer ages 50 experience signs and symptoms, have left colon or rectal cancers, and are diagnosed with more advanced diseases. So in addition to colorectal cancer, they're getting more advanced stuff. Again, probably related to diabetes, probably, cardiac and pulmonary issues, and then renal. It's probably developing, and then again, it's an indicator that they probably have more going on. Okay, so the two main types of pull-ups. Who can tell me what a pull-up is?
It's like a skin tag.
Yeah. It's just adenomatous pull-ups or adenomas. Okay, these pull-ups sometimes change into cancer. Because of this, adenomas are called precancerous conditions, where hyperplastic pull-ups and inflammatory pull-ups, these pull-ups are more common, but in general, they are not precancerous. So when we're looking at the two types of pull-ups, there can actually be two, and the adenomas, they're a little bit more indicative of cancer, of precancer growth. Okay, so signs and symptoms. Let's kill these. Addison, do you want to read these out for us on page number 7?
Sure.
Okay, let's hammer these out, and then we'll move on.
Changes in bowel movements, including constipation or diarrhea that don't seem to go away, feeling like can't empty bowels completely or urgently needing to have a bowel movement, rectal bleeding or cramping, dark patches of blood in or on stool, or long, thin pencil stools, abdominal discomfort or bloating, unexplained fatigue, loss of appetite, and weight loss, pelvic pain, which can happen in the later stages of the disease. Okay, so that's pretty straightforward. So this one, what makes colorectal cancer different than anything else we've studied so far? Is there anything that stands out?
The symptoms don't show till late stages, so you have to just get screened.
Yeah, exactly. You got to kind of detect it just through screening, or as with the case of other kinds of cancer, say for instance lung cancer, do we detect lung cancer in the lungs, or how do we detect it? We don't traditionally detect lung cancer in the lungs. We usually detect it because it goes into the brain and the central nervous system, and there's some of their signs and symptoms. Oh, there's cancer there. We do a biopsy, we check it, and then we realize, oh, those are lung cells. They're not nervous tissue cells causing the cancer. And now we know we have metastasis from the lungs, and now we treat it because of that. We treat it a little bit differently. This one seems like it's got a similar flavor, right? We don't really notice that they got colorectal cancer straight away, but they got other signs and symptoms, and then, oh, wham, bam, oh, they got liver cancer. We go in, we do a biopsy of that liver cancer, and then we say, hey, that's large intestine cells, not liver cells. So they now have colorectal cancer with hepatic cancer or liver cancer, metastasized and moved. So that's what's kind of scary about some of these guys, is that we don't detect the original cancer. We don't detect it until it invades some other tissue, and it becomes bad enough that we can see signs and symptoms in that tissue, in that organ. That's a little scary at the end of the day. Okay, so testing, there's really only 2 tests. We get an occult blood smear test. So who can tell me, Tanner, what an occult blood smear test is?
Well, I just know that occult means it's hidden. Can't remember what the test includes.
Who knows the street version of the name of this test? What do we call this?
Some smear.
Poop smear.
Stool smear?
This is a chance to play with some poo-poo.
Yeah, I bet that's exactly what they say in the clinical setting.
I get to do some poo-poo smearing today.
Yay.
Yep, so stool smear, because cancerous polyps bleed a small amount of blood that is not shown in the stool, but can be detected with a stool smear or a occult blood smear. So whenever I see a occult blood smear now test, I say poo-poo test. I get to play with poo-poo. Okay, and then obviously colonoscopy. So anytime we see the word oscopy, what does that mean?
You've got a camera on a stick and you're going in the body.
Yep, you go and have a look, and oh, there's a nasty thing there. And then, hey, maybe we take a piece of that out with us. We go put it through the lab and see if there's cancer in there, and we go that way. Okay, cool. We get on that one?
Okay.
Okay, so hepatic stuff. We got hepatic. What does the word hepatic mean?
Having to do with the liver.
Having to do with the liver. So there are 3 types of liver disease. There are 3 pathologies to it. What are they? Does anybody know one of them? They're the same as they're same as renal. They're the same as the urinary system.
Prehepatic.
Prehepatic.
Intrahepatic and posthepatic.
Okay, so can you tell us what the difference between those 3 are?
It's either before, within, or after.
Okay, awesome. So in prehepatic, it says it's symptoms doing with the portal vein coming into the liver. You have thrombosis. That would be a blockage due to blood clots. Cancer, you'd have a tumor that grows and blocks the blood going in there. An enlarged lymph node that blocks the blood. Or you just have compression of some kind, a mechanical pressure on the hepatic portal veins coming into the liver. They get blocked, and it blocks the blood flow to the liver, causing prehepatic injury. Okay, intrahepatic, what does that mean?
Within the liver.
Inside the liver.
Yeah, so we're going to get obstruction within the liver, specifically dealing with damage to the hepatocytes, the actual filtering cells in the lungs. They get damaged for whatever reason. So in the case of the example here, it talks about alcohol. So you start having alcohol cirrhosis or alcohol swelling of those tissues. They get damaged and inflamed, and they start blocking the flow of fluid, of blood through there, and the obstruction of bile in the blood. And with those obstructions, you start to get cell death going on. Those cells start to die because they back up and nothing can move past them or through the respective pathways. Okay, posthepatic.
After.
Yeah, so stuff dealing with after. So your 2 renal veins. So your 2 renal veins flowing out. Yeah. And then obviously that's similar to the thrombosis, cancer, anything that's going to block that blood flow leading is going to cause you to have a backflow back into the liver.
Wait, so why are the renal veins involved?
Oh, no, I just used the example that we've already learned sorry, if I said renal, hepatic portal veins leading in, and then hepatic veins leading to the vena cava. So I apologize if I said that wrong. I apologize.
Oh no, you're okay. I was worried I was missing something.
No, I use the example of the renal system that we just learned because the renal system develops pathologies the same way. There's pre-renal, intrarenal, post-renal. Right. And so the liver and the kidneys have some similar pathologies just because of the way that disease processes can happen due to obstructed blood flow and due to obstructed fluid flow through them.
Okay.
Okay, so what was the acronym that we learned?
People drink so much.
Yeah, people drink so much. So P has 3 subcategories under it. Produces ABC.
Bile and coagulation.
Yep. ABC. So ABC. So ABC's first A has to do with what kind of structure, what kind of building blocks. So protein based, right? Mm-hmm. Okay. What's B stand for?
Bile.
So bile's getting disrupted. Okay. And then the last one?
Coagulation factors.
So coagulation factors are being disrupted. So albumin, the primary plasma protein in charge of oncotic and osmotic pressure in the blood veins, is synthesized in the liver. Not enough protein in the plasma means the body fluid in the third space between there is no protein in blood veins to actually pull fluid back out. So what is, when we see fluid being held in the interstitial and extracellular spaces, what do we call that? When it can't be pulled back into the blood, what's that called?
Edema.
Edema. We're gonna see peripheral edema, different kinds of edema because their liver isn't able to. You don't have those large plasma proteins to help to pull that fluid back out. Yay! We get to see edema again. Okay. Okay, so bile. What's going on with the bile system? Well, what bile itself? What is bile? What does it do?
Transports bilirubin and cholesterol.
Okay, bile itself is a digestive
breakdown
fats,
food and stuff.
So bile itself is a digestive enzyme for fats in the small intestine. Okay, but it also has a second function, bilirubin. Okay, and that transports broken down blood, like broken down red blood cells, back to the spleen. It gets it back in, and then obviously cholesterol back into the system, back into the blood. Okay, build up of bilirubin in the tissues causes what?
Jaundice.
Yeah, which is yellowing of the skin. Which, if you ever seen anybody who has this, it's pretty obvious what's going on. And then obviously buildup of cholesterol is hyperlipidemia. Now, why is that scary? What's hyperlipidemia an indicator of? What can happen because of this?
Well, isn't this what can cause like heart attacks and fatty liver and...
I'm going to cheat and help Addison, but she's going to then tell you guys. Art and Arth. Addison, remember those? Remember how we learned that? Art and Arth?
Oh, yes.
Will you explain that to everyone else?
Well, wouldn't it be like the... Gosh, now I can't think. You're putting me on the spot.
Sorry. Remember cardiac?
Yeah, like the...
Arterial sclerosis is one thing.
Yeah.
And then what's the next one?
The arterial sclerosis?
Yeah, arteriosclerosis. So, for the group, tell them what arteriosclerosis and arteriosclerosis is, and what is the relationship with lipids in those? Why is having an elevated lipid level make those?
Wouldn't it be like plaque buildup? Right.
So, arteriosclerosis is what?
The buildup.
Is it occlusion of the lumen, or is it hardening of the vessel wall?
The hardening.
Yep, that's hardening of the vessel wall, which then becomes what?
Then becomes arteriosclerosis.
Which is?
Like the plaque buildup or the lumen occlusion.
There you go. So for the rest of the team, for Sandra and Tanner, increased lipid levels in the blood exaggerate and acerbate arteriosclerosis and arterial sclerosis. Arterial sclerosis meaning hardening of the blood vessel and artery walls. Arterial sclerosis is the actual buildup of plaques and other substances that cause lumen occlusion in our arteries. Elevated lipid levels makes that worse and happen more.
Makes sense.
Okay, are we good? Any questions on that one? So that's the second order thinking on that particular piece of information, that it's not so much of a big deal for the liver and the blood itself. It exaggerates pre-existing arteriosclerosis, and then it will also just make the addition of plaques and buildup on the tissue walls, arteries more exaggerated, to lumen occlusion or blockage of blood through those blood vessels. And the word for that is ischemia. You'll start to see ischemia happening. You get a blockage, the tissue below that starts to die. Okay, so that's the higher level thinking from just, oh, I've got elevated lipid levels. Okay, well, whatever. Okay, and then coagulation factors. How are those affected by the liver?
They produce them.
Yeah, so platelets are produced where?
In the bone marrow?
In the bone marrow, but platelets themselves are not the complete clotting factor. Platelets are the building block, but they need some helper bees to help them do their job. Where do the helper bees come from?
That's coming from the liver.
The liver. So if the liver's impaired, the platelets will not do their job and they won't control bleeding as well. Okay. D. Everyone's favorite. This is the one that we don't want to stop working.
Detoxes.
Detoxes what specifically? Ethyl alcohol. Okay, ETOH is ethyl alcohol, just so you guys know that acronym. and then obviously the liver is detoxing the drugs and other toxins in the body as well. So if you lose the liver, you lose the ability to detox your blood of those poisons and those elevated substances. Okay, storage of glycogen. What storage of glycogen got to do with anything?
It has to do with everything. Like our brain needs sugar and we can't, so we store it as glycogen and break it out when we need it.
Yeah, so we don't have all kinds of free-floating glucose in our system. So the liver holds on to it. So when our autonomic nervous system kicks in and fight or flight kicks in, the liver dumps glycogen back into the system, which then helps to become sugar that can be recruited as energy. It's a rapid supply of energy for the body. So that's one of the key functions. So if our liver starts becoming damaged and we start losing liver function, we also lose our fight or flight response. We won't have a rapid storage of energy that'll dump in order for us to deal with the fight or flight situation. And then finally, metabolism of proteins. Proteins digest in the small intestines. Ammonia byproducts build up. The liver then metabolizes that ammonia into urea, sends it to the kidneys to removal of the liver. So if the liver starts dying, you start to get a buildup of ammonia in your system. And we learned before that ammonia is what to the body?
Poison.
It's poison. Okay, let's talk about cirrhosis. How much fun is that?
So fun.
Okay, so cirrhosis by definition means what of the liver tissue?
Hardening? What is it?
It just means scarring of the liver tissue. It's just about scars. And remember from the video that we watched, it just means there are little bumps that start to develop, little hard spots that start to develop because the hepatocytes start to die because they're hardening up. And you'll start to see as little bumps on the outside of the liver. Normally the liver's got that kind of dark, smooth color. This will start to discolor it and you'll get little bumps on the liver surface. Okay, most common cause of cirrhosis is what?
Too much alcohol?
Alcoholism?
A little bit of too much grandpa's cough syrup. Okay. Which it comes back to acetaldehyde, which damages the hepatocytes. So your body can only process so much ethyl alcohol per minute or per hour. You get too much, that alcohol becomes acetaldehyde, and then it starts to damage the tissues around where those spots are. Okay, cirrhosis can also be caused by viral hepatitis and other hepatotropic drugs, other drugs that are active in the liver. Okay, but the primary one is again, one of our key ones, drinking alcohol is going to damage your liver. So if you engage, just be really cautious and do it with some wisdom, and don't die because you get nasty liver and get killed. Okay, so the scar tissue just prevents normal flow of blood through the liver, which obviously keeps it from doing its job of filtering and creating clotting factors and creating urea, all those key functions. And so you're good, and that's going to cause that buildup of all those things in the hepatoportal system. Okay, portal hypertension here is what it says, but that's the flow of blood into the body. So if you're getting blood pressure and fluid buildup in the hepatoportal veins, what other organs are going to be affected by that? What's the first spillover organs?
From the liver?
So the structures that feed blood through the hepatic portal veins to the liver. What are those structures that flow through the hepatic portal vein?
The intestines weren't isn't that what you were saying earlier?
Yep. Large and small intestine, but also the spleen flows blood through there too. Okay, so this is an anatomy and physiology review. If you don't understand that, what systems flow into the hepatic portal system, what other organs, you may want to look at that and get a little bit familiar with it, because then that kind of helps you kind of figure out why the spleen becomes enlarged when the liver starts to die. Okay, so fluid backup number 1 in the little box here, it says causes portal hypertension. High fluid volume pushes fluid into other organs and blood vessels. Esophageal varices, hemorrhoids, and then splenomegaly. And then protein loss, number 2, decreased protein in the capillaries, no pulling action to draw fluid out. So we get ascites and lung congestion. So what's ascites? I don't even remember what that is. Does anyone remember what those are? Ascites?
I think they call them ascites.
Is that what it is? Ascites?
I mean, I could be wrong.
I'm gonna do a quick Google bad boy on this guy. Hold on. I don't remember that.
That's just when you have like the abdominal cavity filling up with fluid. And
okay, there we go.
They talk about like drawing it, people that get it drawn out every week, because it just collects. Like draining it just is a temporary fix. It's going to collect again.
So what was the name of the procedure that we used to pull the fluid out?
Paracentesis.
Paracentesis, right? So we get a big needle, we stick it in there, and we go, then we vacuum cleaner that stuff. Okay, I have to just say that now, remembering what that is, that sounds really painful.
Yeah.
I'm okay not having that happen to me.
The other stuff we've been talking about, no problem, anytime.
Well, no, there are some that, like, okay, you get an MI, you just die, right? You untreat an MI, it's painful for like an hour, and then you're dead. This, you could be dealing with this for years, and it would be like really nasty, painful for a long time. I'm okay not doing that.
Yeah, I'm okay with that too.
I'm totally okay with that. Okay, clinical manifestations. Hepatic portal hypertension, obstructs flow to the liver, buildup of fluid in the portal veins, and organ enlargement. Okay, splenomegaly. Who can tell me what splenomegaly is?
The enlarged spleen?
Large spleen. And what does the spleen actually do? Its job that would be impaired by splenomegaly.
I cannot remember what the spleen does.
Spleen, do you remember? Addison, Tanner, do you guys remember? Tanner? I'm giving the male lifeline to you. Do you remember?
Let's see. Hold on. Let me think. I mean, I think it's another.
Tanner, come on, Tanner.
I think it's another filter of the blood.
It does work with some blood components. What exactly does it do for blood components? Which blood component does it work with? Red blood cells, white blood cells, or platelets?
White blood cells.
Red.
Red. Who said red? Who said red?
Dang it.
Does it like eat up the platelets, or like what? It does something.
It removes old and damaged red blood cells and breaks them back down into their iron and different base components.
But doesn't the liver do that too?
That's what I was thinking.
Discriminates. The liver helps to discriminate which ones are old and which ones are young by pushing them into like bile. And in
No, I thought didn't like the video we watched, like we saw them like eating them.
Yeah. Well, the liver has some assistance, but we also know that the spleen is very, very key to that process as well.
More of that.
Okay. So if we have splenomegaly, what are we not now doing then?
Filtering the blood.
We're not releasing.
Getting rid of those bad red blood cells.
When those red blood cells start to die off, the old ones, when grandpa red blood cell dies off, we're not recovering the iron from that hemoglobin cell, that hemoglobin part of the red blood cell. And do we want to give up that iron? If we can recover a perfectly good source that's already there, is it easier to recycle that one or to have to eat and bring in new iron? What's easier for our body?
Recycling is always better.
Recycling is always less energy intensive, and the body likes to do it more often.
It says online that the spleen recycles old red blood cells, and it stores platelets and white blood cells.
There we go. Okay, so there you go. But again, the primary function of the spleen, the one that we can't live without, is the breakdown of those red blood cells and recovering those components. Platelets and white blood cells, if we lose the spleen, we lose a portion of our immune response, but not all of it. We lose a portion of our clotting reserve, but not all of it. There's still platelets and stuff flowing and white blood cells and flowing through the system. But if we lose that ability to break down that red blood cells and recover those components, that is very, very quickly going to cause us to get anemia and to have low oxygen levels in our blood. It's going to make it very difficult for the kidneys and the bone marrow to produce more red blood cells. Okay, we good?
Yeah.
Okay, let's move over to page number 9. Okay, hepatoencephalopathy. Well, who can tell me what the word encephalopathy means? Pull that word apart and tell me what it is.
Pathy is something wrong.
Yeah, it means something's wrong, right? Encephalo means brain. So we have hepatic issues going on that are affecting the brain.
Okay.
Okay, so the damage in the liver will break down or synthesize proteins which result in elevated ammonia levels. And where is that ammonia going to flow?
To your brain.
It's going to flow to the brain eventually, and that's poison. So you're going to have a change in your level of consciousness. You're going to have a personality disorder really quickly. Okay? That ammonia can cross the blood-brain barrier and cause you to start to have LOC changes. Okay? Jaundice. We already talked about jaundice. So what's going on with jaundice?
The bile is not carrying away the bilirubin.
Yeah, bilirubin is found in the red blood cells now. So jaundice, damaged liver cannot break down the bilirubin. So it then flows into the blood, and then the bilirubin deposits in the skin and sclera of the eyes, turning the skin and sclera of the eyes yellow. Okay, and then it causes intense pruritus or itching of the skin. Again, that sounds really not fun.
Yeah.
Okay, and then hepatorenal syndrome. So Addison, do you want to cover this one for us?
Sure.
Get this one for us.
Okay. Decreased
It has your
circulation.
favorite system in it.
It what?
It has your favorite system in it.
You have a favorite system? So jealous.
I don't know.
She likes the
What's my
RAS.
favorite? Oh.
Addison
Okay,
made
so
really cute flashcards for the RAS system.
Gotcha.
I did. Decreased circulating blood volume leads to decreased renal perfusion, triggering the RAS system, vasoconstriction, and increased blood pressure. Hepatic.
So what part of the RAS system is this affecting if you're getting vasoconstriction?
Sorry, can you say that again?
So, okay, in the RAS system, there was one component that specifically affected blood vessel diameter? Does anybody remember which one it is?
I can like see the
aldosterone.
picture in my yeah.
Okay, well, and as you're looking it up, we'll talk through it. So where does the RAS system start? What are the two organs that start the RAS system? The kidneys and the liver. So the kidneys secrete what?
Renin.
Renin, and the liver secrete what?
Angiotensinogen.
Angiotensinogen. Those two combine in the blood system, in the blood vessels to become what?
A1.
A1, angiotensin 1, right? Then angiotensin 1 flows where?
To the lung.
The lungs.
And what does it interact with there? It goes to the lungs, which is the dance party.
ACE.
It hits ACE in the dance party in the lungs. So angiotensin 1 and ACE come together in the lungs to become what?
A2.
A2. A2 does what by itself?
Vasoconstriction. No.
Angiotensin 2 is a
Stimulates the renal cortex.
Yeah.
Is a vasodilator. So if the angiotensinogen from the liver is disrupted, angiotensin 2 will not be created in the lungs, and the vasodilating feature of angiotensin 2 will not happen, which causes vasoconstriction to happen. Hey, I know that was kind of long and elaborate. I apologize, but that was a good review of the RAS system and what the role of the liver in it is.
Yeah, I need the reviews.
Okay, so angiotensin 2 has a vasodilating feature. Because remember, we have low blood pressure is what the RAS system is working with, and it's trying to drive it up. We're trying to drive it up. Trying to drive blood pressure up, right? Is that correct?
Yes.
Yep.
Okay, and so we have to drive that up. One of the features of driving blood pressure up is to make the can that blood is in, the volume of blood vessels in, smaller. So angiotensin 2 vasodilates, or excuse me, it vasoconstricts. Angiotensin 2 vasoconstricts and makes the blood vessels smaller. By making the blood vessels smaller, it's going to increase cardiac output and drive blood pressure up. So if the liver is,
I thought that was aldosterone.
Aldosterone raises blood pressure a totally different way. Can anybody remember how aldosterone works? Aldosterone's created where? How is aldosterone created? Angiotensin 2 goes through the blood vessels back to the kidneys, but it hits a very special structure in the kidneys.
Yeah, the cortex.
Renal cortex, and then the renal cortex, it's converted to aldosterone, and aldosterone has a very, very, very special function.
It vasoconstricts.
It tells
that's angiotensin
2. Angiotensin 2 is the vasoconstrictor.
So we were wrong. Aldosterone is sodium and fluid retention.
There we go. It tells the kidneys to hold on to sodium, which in turn, water follows the salt. So aldosterone just tells the kidneys to hold on to salt. It's angiotensin 2 that has the vascular feature.
Right.
I had that mixed up in my head.
That is exactly why I went over that, because we just took the quiz on the renal system, and we're already starting to forget that. And how much time did they spend beating us up on that?
I don't know.
Quite a bit.
They spent quite a bit of time talking about the RAS system and the the natriuretic peptides, ANP, BNP, which is the blood pressure lowering system. Okay, that's it. Just at the liver. So if we remove the liver from the RAS system, everything down the line cannot happen, because renin stays renin. Renin doesn't get converted to anything else. It just renin's floating through the system, and it's going by these structures saying, hey, raise the blood pressure. And these guys are like, we don't recognize you. We need something else to come talk to us. Okay, are we good? I beat you up on that. Sorry. Okay, keep going. Addison, do number 2 for us.
No, thank you very much.
No, that's, again, you have to understand the previous stuff to make sure you understand, or you're just lost in the sauce. It's like trying to do calculus without understanding algebra. We have to understand the algebra, or we just can't move forward. So if I push on something like that, it's because I've looked at it and that key feature is there. Okay, we good?
Yep.
Yes, sir.
Okay, we're good. I'm going to shut up on that now. Let's hit number 2. Addison, will you read number 2?
Okay. Hepatic failure prevents removal of excess angiotensin, so the process is not reversed and HTN gets worse.
So HTN stands for what, guys?
Hypertension.
The hypertension. So if you have high blood pressure, you're just going to continue to have high blood pressure. Okay.
Mm-hmm.
Number 3.
Following the kidney damage, less urine is removed from the body, so waste products that contain nitrogen build up in the bloodstream.
And there's the key word. What's that word right there?
Azotemia.
Azotemia. And azotemia, by definition from our previous section, was what? There's a cheat on the side. It'll help you with this. Look at the next box over.
About the bun and creatinine?
So increased bun, increased creatinine. But remember, there was azotemia and there was uremia. And they both had differences on both had elevated bun and elevated creatine. One had a systemic response and one had no systemic response.
Oh yeah.
Okay. So can you remember that? Okay, so everybody, so for Sandra and Tanner, I think Addison remembers these. So Addison, azotemia and uremia, which one had a systemic response and was more dangerous? Was further along?
The one without the systemic is the azotemia.
Is that more or less dangerous than one that shows systemic response?
Wouldn't that be less?
It's less dangerous.
Yeah.
It's less dangerous, and why?
Because there's no systemic response.
Because our body is coping with the elevated bun and creatine levels.
Yeah.
Okay. So Sandra and Tanner, did you guys understand that?
Yeah, I just didn't remember that at all. I remembered that azotemia had no signs and symptoms despite the elevated bun and creatinine.
Yes.
Creatine, but I didn't realize it was like systemic versus non-systemic.
Okay, so there's 2 words. They're not showing the second one. Azotemia means there's elevated bun and creatine in the blood, but not another response. So the kidneys aren't responding. The lungs aren't responding. The heart's not responding to that, right?
Oh,
the
yeah.
body is compensating for it.
Gotcha.
Uremia shows increased elevated bun and elevated creatine, but there is other systems starting to respond to it. The heart,
system organ failures. Yeah.
there you go. So
Okay.
other systems are starting to be affected by those elevated levels and be damaged. That's the difference.
Yep, got it.
Okay, again, that's why I beat that up, because again, we got to remember those previous lectures and those previous sections, and the liver and the kidneys have some really, really key functions to each other. Okay.
So, sorry, one more time. So uremia has the increased bun and creatinine levels, but there are responses and signs and symptoms from other systems.
Yes, other organs are going to start to show the wear and tear of increased bun and creatine, but azotemia, what are we not going to see?
Signs and symptoms.
Yeah, we're not going to see any other signs and symptoms anywhere else. Other organ systems right now are compensating for the elevated levels. They're like, yeah, we're okay right now. We can deal with this.
Perfect.
Okay, we good? Can we move on?
Yeah.
Yep.
Okay, I know that is really fun for everyone when I stop and slow down and
No,
really.
wait, I need those. That's what I need.
Okay, I just want to make sure that I don't turn into the massive teacher. I'm like, I want to do it for the team, and then it's productive for you guys. Okay, so Hart syndrome, hepatorenal syndrome, occurs in up to 40% of patients with liver failure. Prognosis is poor because renal failure is irreversible unless liver transplantation is performed. So if you start getting hepatorenal syndromes, associated symptoms between the renal system and the hepatic system, these people are going to die. Okay. Hepatoencephalopathy, we talked about. What's this one? What happens here with hepatoencephalopathy? encephalopathy.
Encephalopathy.
I can't say that right.
Oh, I remember. Right?
We just talked about this, right? This is when the
blood-brain barrier.
Like
ammonia goes where? Ammonia flows where?
Through the blood-brain barrier.
Through the brain. We start acting like an Alzheimer patient, and then what's one of the dead giveaways that it's liver damage, dealing specifically with hepatic encephalopathy?
The hand flappy thing. This is the only sickness that symptom shows up with.
Yep. As trick-6 are flapping tremors in the hands. So right. Okay, that's an early sign of hepatic failure and hepatic encephalopathy. Okay, they just involuntary move when the wrist is extended, causing metabolic encephalopathy of any change, but especially decompensated liver failure. Okay, so if we hear compensated, remember from our blood lecture, our hematology lecture, we have compensated, uncompensated, and partially compensated.
Mm-hmm.
So
that's one of the things I need to review.
Yep, decompensated liver failure means what? It means you are not responding. Your body's starting to be damaged because your liver is done playing the game. Okay. The number of flaps per minute correlates with the severity of the syndrome. So if you get small flaps, they're okay. If they're trying to swim with their hands, they're pretty advanced. Okay, so let's moving right along. Number 9. Okay, number 10. So paracentesis. So you can tell me what paracentesis is.
That's the one we talked about, getting the fluid out of the abdomen.
Yep. The ascites is collected in the abdomen, or it's called peritoneal fluid. And then how do we pull it out? We stick a big tube on there. We just start putting 2-liter bottles on the end and start collecting it up. Okay, so the key thing with the key thing for us as caregivers with paracentesis is what? What can we do to these people?
It's just to relieve discomfort. It's not for anything else.
Okay, so someone's got like 3 liters of fluid in the bottom of their abdomen. We start pulling that out. We start removing it to give them comfort and to help relieve the symptoms of that fluid in there. What have we just done?
Possibly infected them with the tube that we stuck in, right?
Well, that's clearly a situation where that can happen. But anytime we start draining something from the body artificially, what's the first system that's going to be affected by the drainage? They're gonna clear.
Oh, our blood pressure.
Thank you. There it is. Anytime we drain any kind of fluid from any kind of part of the body, anytime we intervene like that, we're going to affect the blood pressure first. We've now created a hole, an empty space in the body. What does the body want to do to empty spaces that aren't normally there? What does it like to do? It wants to fill them back up with something. So when we do that, we've opened up this space now on the bottom of the abdominal cavity that was filled with nasty fluid. So the first system to try to compensate and to fill that back up is the hematologic system, the blood system. And so what we're going to see is a drop in blood pressure because we're going to open up blood vessels. Those are going to start to open up, and there's going to be more space in those.
Are you sure that's what that is? I thought it was like, when you say open it up, are you meaning like their walls are going to open up and fluid is going to come out of the vessels? Because I think it's just like the vessels were compacted because of the fluid, and then once the fluid is gone, they can just expand more.
That was exactly where I was going. Sandra answered it. Does anybody understand? So can anybody else, Tanner or Addison, explain in your own words what Sandra and I just talked through? Can you explain it to us back?
So from what I understood, the fluid in the abdomen was compressing the the vessels around it, so that it couldn't flow very well. And then now all of a sudden, all of that fluid is gone, and they were able to just relax or expand more, resulting in lower blood pressure, I think.
Yeah, no, yeah. So what's happened? Addison, do you have anything you want to add before I jump in and try to answer this, or Sandra?
Just that it's not necessarily like bad, right? Like
yeah. So what's happened is that the I can't say this, ascites. It's built up over some time, right? It slowly built up, and so it slowly started to compress the blood vessels and the structures, the lower abdominal organs, over some time, right? It hasn't happened overnight, and so the blood vessels and those organs have all been compressed slowly. Okay, we go and remove all that tissue. What do all those blood vessels and organs do when we remove that tissue quickly? They shift to fill that space back up, which causes those blood vessels are the first thing to start to expand and open back up. And because we've expanded them, we've actually vasodilated the system. Right? Or excuse me, yeah, we vasodilated the blood vessels. So whether we use RAS or we use ANP or whatever, anytime we vasodilate the blood vessels, we make the can larger for that the blood's actually sitting in. And anytime we make the can that any fluid is sitting in larger, we decrease pressure. The actual pressure of the fluid is lower. Okay, so we're not actually bleeding into that space. It's just that like Sandra said, when we relieve the fluid that's in the extracellular fluid, anything in intervascular space and intercellular space is going to be expanded, and it's just going to cause the blood pressure to drop because it's blood pressure that works to fill that space.
The ascites is just a form of involuntary vasoconstriction.
There we go. So Addison, are you on the team with that topic and why that happens? Okay. Tanner, you sound like you're on the team now. You get it.
I think I do, yeah.
Okay, Addison, are you on the team with that?
Yes.
Okay, everybody's kind of got that. And thank you, Sandra, for saying it's ascites.
I
Yeah.
think I remember that's what they said in class, but you know.
I struggle with it. Okay, let's hit the lab test really quick. So Tanner, will you read the first lab test?
Yeah. LFTs, or liver function tests, specifically the liver enzymes ALT and AST, increase when liver tissue has been damaged, allowing the enzymes to escape into the blood.
Okay, CBCs, do you want to hit that one, Sandra?
CBCs are done to check the RBCs and platelet status.
Yep. Addison, you want to hit ammonia?
Yep. Levels are monitored due to the liver's decreased ability to break down protein. High ammonia levels cause and I can't say that word. Encephalopathy. Brain damage.
Okay, bilirubin. If liver does not make bile, bilirubin, blood breakdown byproduct, is not cleared from the blood. Tanner, do you want to hit the next one?
Yep. PT, PTT, and INR will be drawn to test for bleeding problems.
Okay, so before we jump ship on these, I need to review these two. Where did we cover PT, PTT, and INR originally? Where was this covered?
No idea.
Coagulation, right?
Yeah. These are blood tests from blood, from hematology. So I'm not going to cover these right now, but I'm going to ask that everyone away from here before tomorrow or the next time you come to study group, review those. And let's have a discussion collectively because I don't remember them either really well. So is that a fair request of everybody? Personal study. Yeah. Take a few, go run these down and figure out what the hell they are and how they work. And then collectively we'll get together again, we'll meet again, and we'll go over these again. Okay?
Okey-dokey.
Okay, and I said, let's not have a discussion about it right now because we're running out of time for our hour, and then we'll just push on, okay? Occult blood smear test. Who was next to read?
Me.
Okay.
Occult blood smear, a.k.a. playing with poo-poo.
There we go.
Test the stool samples for occult blood.
Okay, awesome. And occult means what?
Hidden and not visible to the naked eye.
Hidden poo-poo. Hidden blood poo-poo. Okay. Caca, whatever you're calling it. Okay, I'm sorry. It's just fun to say poo-poo. Okay, it's fun to say poop. So anytime I can say poop around encephalopathy and ascites, I'm going to say poop. Okay, I'm going to just do that.
You're in the right field of study, I guess. If this turns you on.
I didn't say I wanted to say I didn't say I wanted to play with diarrhea.
You said you loved it. That's what we took away from this.
Here we go. Here we go. Can you smell my sarcasm with my poo-poo? Okay, viral hepatitis. Here we go. Viral hepatitis. Let's talk about some viral hepatitis. Hey, before we talk about what hepatitis is, can anybody explain? Does anybody remember the 3 types of hepatitis and which ones have a treatment and which ones do not?
Me.
Sandra, please.
A, B, C, and A has no treatment, but C has no treatment, but A and B have a vaccine.
Yep, they do. So let me ask a question to anyone else. Can anyone remember why C does not have a vaccine?
It mutates too fast, right?
I cannot remember.
Addison, do you remember?
I don't. Let me look.
They talked about how it mutates too
There
fast.
you go.
So what they didn't explain is why does C mutate so much and A and B don't mutate as much? I didn't really get that.
I think it has to do with its DNA setup and the different antibodies and antigens on its cell wall. So when it permeates another cell to procreate, it leaves multiple different kinds of antibodies on the new plasma membrane of the infected cell, and it basically picks whatever one it wants genetically. And so we can't vaccinate against all the different the antigens that are on this that it picks as its cell identifier. And so that's why we can't vaccinate against it, because we're not able to. We can't war game 200 million different antigens that could potentially be there and vaccinate against all of them.
Thank you. That makes sense.
Okay, that's why where A and B, there are specific genetic and antibody tags that are on the cell wall that we can identify and vaccinate to, and that's what the vaccines go after.
Okay.
Are we good? Does anybody have any issues with that?
Nope.
Okay, so chronic hepatitis or hepatitis attacks slowly. It's not a fast attacker. It's a slower one. So this person can have hepatitis for years before they develop any signs and symptoms, which is a little bit dangerous because, as we've learned before, when a disease attacks slowly over time with no signs and symptoms, by the time we detect it, how serious is it?
It's a big deal.
Yeah, so by the time it is visible or it presents with any signs and symptoms, you're down the rabbit hole. And now we got a really, really big problem, as opposed to, yeah, they got some minor stuff. We can deal with this. Okay. So it's undetected. Okay. Let's talk about how hepatitis A, B, and C, how are these passed on to someone else? Do you guys remember? Hepatitis A has to do with some poo-poo. Remember, hepatitis A is the poo-poo hepatitis. Hepatitis is poo-poo to mouth. Fecal to oral contamination. The virus is on someone's poo-poo. They don't wash their hands. They touch your food at the McDonald's, and now you get it because you eat it.
That sounds terrible.
Let's go to the McDonald's and let's make sure they wash their hands. So Hep A is passed on by oral fecal transmission and it's foodborne. But Hep B and Hep C, those guys are passed on how?
Sexually.
Yeah, that's one of the ways. So you go to the club and meet somebody, you take them home, and they may give you the Hallmark card, the gift that keeps on giving, Hep A and Hep C. I mean, Hep B and Hep C. Okay, so be careful who you're bringing home with you. Okay, if Hep C and Hep B can be transmitted by unprotected sexual behaviors, what else can transfer it? A damn contaminated needle?
Yeah.
So you're shooting up the old heroin with your buddy over on State Street. You share that needle, and he's got Hep B and Hep C. Guess what you just got?
Both. Yep.
You just got yourself a raging case of herpes. I'm just teasing. You got yourself some hepatitis from him.
Hepatitis, yeah.
Okay. So what I'm saying is, so basically, you just should have had sex with him as you shared the needle with him. I mean, like, you know, double your pleasure, double your fun. I mean, if you're going to get hepatitis, you might as well get the full show, you know? Okay, so let's hit these signs and symptoms really quick, and then you guys, I think we'll be done for the day. Is that cool? Anybody got any issues with that?
We're good.
Because I'm getting tired. An hour is plenty for me.
Yeah.
Okay, so signs and symptoms. We're back on page number 10. So let's just hit these. Let's hit these fast. So number 1, who wants to read the first box?
Can be either acute or chronic.
Someone else. Box 2.
Fatigue, weakness, or loss of stamina.
Okay, 3. Sandra, do you want to hit 3 for us?
Vomiting, diarrhea, anorexia.
Okay, 4. Fever and flu-like symptoms. Okay.
Dark colored urine.
Ooh, that sounds like fun.
Ooh.
Okay, then we got the big J. We got some big J in the house again.
Jaundice of skin and sclera.
Yep. And they call that Icarus or icterus, which is that nasty itching on your skin. Awesome. And then intense purpuritis due to Icarus. These are all only signs and symptoms that are specific to lizard disease. Okay. You guys good? You want to move on? We're done?
Yep.
Okay. So I'm going to have us back on at 9. I'm going to email the other people in the group. Are any of you going to get back on at 9, or are you going to be done for the night?
I'll be on at 9.
Okay. Okay.
Yeah, it depends on where I'm at, but
Okay.
I'll try to be.
That's fine. So I will be back on at 9:30. So just for those of you that are here, I'm going to start back at slide number 1. And I'm going to work through material that we went through yesterday, as well as the new stuff that we added today. I'm going to try to hit it all again.
Okay, I might be back tonight if, as you can tell, I'm like
Going somewhere.
running around with kids. But if,
In the car.
but I'm gonna try.
So what you're saying, Sandra, is that you have embraced the digital study group because you can be doing other stuff.
I am doing other stuff. I'm doing it all at once.
You're
Wow.
like the 21st century woman. You know, you're.
I mean, I might be doing a crappy job at all of the things, but you know.
Well, you got an hour of studying that you wouldn't have normally gotten, so that's good.
I know. I really appreciate it. Thank you so much. Hopefully, I'll see you guys later.
So announcement. So on Saturday, we're at 1 o'clock at the library in Rose Park. It's called Bay Riverside.
Okay.
Hey, that sounds like crap, but Addison and Harmony and Adriano all live north in Roy, Bountiful area. And so those of us that live south have embraced the fact that we meet at Rose Park, which is kind of midway for everybody.
I think I can be there.
Okay, and it's 2 hours. We go for 2 hours that day. It's a face-to-face. If you cannot come, I'm still going to blog that study group. I'm going to blog it to the net as well.
Okay, where's some good parking there?
There's plenty of parking there.
Okay.
It's a public library, and they have a huge parking lot. You shouldn't have any issues parking there.
Okay, awesome.
And I'll send out an email or a text with the address again. But if you just Google Day Riverside Salt Lake Library, it'll come right up. It's out in Rose Park. It's the only one out there.
Okay. Thank you, Chris.
Okay, see you later, guys.
Thanks, guys.
Okay, peace out.